All right, welcome. Today, we're going to talk about a really interesting way of looking at psychotherapy. It's called multimodal therapy. And it's all about this idea that we should be treating the whole person, not just zeroing in on one single symptom.
So let me ask you something to get us started. Think about anxiety, something most of us have felt, right? But what is it? Is it a racing thought you can't shut off? Is it that knot in your stomach? Or maybe it's sweaty palms, that feeling of dread? The truth is, it's not just one of those things. It's all of them, all at once, and probably more.
And that experience right there sets up the big question this whole approach tries to answer. I mean, we are incredibly complex creatures, right? So it kind of begs the question, why on earth would we think that some single, one-size-fits-all therapy could possibly work for every person and every unique problem out there?
This leads us to a really core idea called technical eclecticism. It sounds a bit academic, but the concept is actually pretty simple and kind of revolutionary. Instead of all the different schools of therapy arguing about which theory is right, this approach says, hey, let's think of therapy more like a toolbox. The goal isn't to prove your hammer is better than a wrench. The goal is to look at the job in front of you and ask, what's the right tool for this person and this problem right now? It's all about what works.
So who was the architect behind this very practical, common-sense idea? Let's meet the pioneer of multimodal therapy, a psychologist by the name of Arnold Lazarus.
To really get multimodal therapy, you have to understand where Lazarus came from. When he was training back in the 1950s, everything was about psychodynamic and person-centered theories. That was the water he swam in. But he also got exposed to this new thing called behavior therapy, and instead of picking a side, he started mixing and matching techniques. This gave him a much broader perspective than most of his colleagues at the time.
And this led to his huge aha moment. In the early 70s, he did something incredibly simple but profound. He just followed up with his old clients. He checked in to see how they were doing. And he discovered a crucial pattern. The people he'd treated with only behavior therapy, a lot of them had relapsed. But, and this is the whole key, the clients who had gotten a combination of behavior and cognitive techniques, the results were so much more durable. They stuck.
This powerful realization that a broader approach leads to lasting change led him straight to his breakthrough. He created a systematic, comprehensive framework for understanding and treating the whole person. He called it the basic ID model.
The entire model is built on one powerful, guiding idea. It basically argues that unless you take the time to assess 7 distinct but totally interconnected parts of a person's life, you are almost guaranteed to miss something important. You're leaving clues on the table.
So what are these 7 dimensions? Well, they form a very handy acronym that really is the heart and soul of this entire therapeutic model.
And here it is, BASID. Think of it as the blueprint. B is for behavior, the things you do, your habits, your actions. A is for affect. That's the world of emotions, moods, and feelings. S is for sensation, the purely physical stuff like tension in your shoulders, dizziness, or the feeling of touch. I is for imagery, your inner world of mental pictures, your self-image, dreams, and fantasies. C is for cognition, your thoughts, your beliefs, the stories you tell yourself. The second I stands for interpersonal, which is all about your relationships and social life. And finally, D is for drugs and biology. This covers your physical health, diet, exercise, and any medication. See? Altogether, they create a complete picture.
So, okay, we have this brilliant framework, but what does it actually mean for therapy itself? How does this make the whole experience different for the person seeking help?
Well, first and foremost, even with this very structured approach, the human connection is absolutely central. You can think of the therapeutic relationship as the soil. The best techniques in the world are like seeds. They won't grow without good soil. It all starts with empathy and trust. And a key technique here is called bridging. It means the therapist meets you where you are. If you come in talking about your feelings, your affect, they start there. If you're focused on physical symptoms, sensation, that's the entry point. They learn to speak your language first to build that trust.
This relationship is much more like a coach working with a trainee than a distant doctor-patient dynamic. And that partnership is what allows for the next step, which is called tracking. Together, you literally map out the firing order of a problem. Let's take an anxiety attack. It might start with a catastrophic thought. That's cognition. That thought creates a mental image of failure. That's imagery. That image triggers a feeling of panic, affect. And that causes a tight chest, sensation. By tracking that whole chain reaction, the therapist knows exactly where to intervene to be most effective.
And this is what allows the therapist to become what Lazarus called an authentic chameleon. This isn't about being fake. It's about being flexible enough to connect with a client through bridging and having the insight from tracking to guide them effectively. One person might need a direct, no-nonsense coach. Another might need a much more gentle, supportive listener. The therapist authentically adapts to be what that specific client actually needs to make progress.
So the real genius here is in the whole design. It's comprehensive, it uses the basic ID to make sure nothing important gets missed. It's systematic, which gives both the therapist and the client a clear map so the process isn't a mystery. It's deeply personalized because it tailors not just the techniques but the entire relationship to you, and because of all that, it's designed to be efficient, aiming for change that actually sticks by addressing the problem from all 7 angles. This whole approach leaves us with a really big thought. When we think about the future of therapy, maybe the point isn't to find the one single theory that wins. Perhaps, like Arnold Lazarus suggested, the real goal is to stop competing and start collaborating, to just focus on building the most complete, flexible, and effective toolbox possible for every unique human being who walks through the door. What do you think?